I would like to make a comment, Fayed, to your second last slide. We already discussed in London in the European Society of Cardiology meeting. I don't agree on that slide at all, in particular to the benefit of the drug. There is metformin on the right-hand side with a question mark, and probably it relies to the famous UKPDS 34, which was an underpowered study. So metformin, from my point of view, has to be put in the middle, uncertain. Second, pioglitazone, as Rangbi has said very well, at least has to stay in the middle, because in the proactive study, the secondary endpoint was reached significantly. The post-hoc analysis on the myocardial infarction patient and stroke patient was absolutely positive. So from my point of view, at least you can put it in the so-called uncertain position. And also the DPP-4 inhibitors. We all know that the studies you described very well are cardiovascular safety trial, are not cardiovascular outcome trial. And we know that in the preclinical studies, DPP-4 inhibitors seems to have a positive effect on cardiovascular outcomes. So I think DPP-4 has to be put in the middle. So I don't agree with these slides. Sorry for being so rude, but this is my opinion.
No, it's not because you haven't read very much the slide. On the left-hand side...
But if you want to show this, the second last.
Yeah, this is important.
This one.
And I did change this slide, actually, because it doesn't say no benefit on the left-hand side. It did say no proven benefit. So it's a level of evidence. Benefit is still likely if we have...
and what the reason of the middle? Uncertain outcome. So I think that the pioglitazone deserve to be put in the middle at least. This is my point of view.
It's just a matter of level of evidence. When you have got positive result in sub-analysis or post-hoc, the level of evidence is not sufficient to have a recommendation of class 1 and level of evidence class A. So we can argue that for some time, but anything in the green right-hand side is very strong evidence. While metformin, I have put the question mark in order not to shock much our diabetologist colleagues here, because they are strong believers in metformin. And
I'm not.
You're not. So this is the reason.
In terms of cardiovascular benefit, it's an excellent drug, but in terms of cardiovascular benefit, there is no evidence.
And this is the reason I have this question mark. There is some evidence, but in my opinion, there would be in the future, I am pretty sure, a head-to-head comparison of metformin versus any one of the new drugs is going to be beneficial, maybe the empagliflozin or some other drug. So I essentially agree with your point, but it's a matter of level of evidence.
Would you like Stephen and Jürgen chip in this discussion? What do you think?
I mean, I agree. One has to be really cautious.
You agree with who? With me or with him?
With him.
Say it again, please.
I think,
okay. Then I ask you, why incretin therapies are in the middle? Why incretin therapies are in the middle and not in the left-hand side? ELIXA is similar to Examine.
Stefano, you can do this over a cup of coffee, but I would like to hear your opinion, Stephen.
I think you've got to be really cautious with subgroup analyses. I think that's critical. In fact, in line with that, your comment about metformin is a reasonable one, because I mean, in large degree, that data is subgroup at best. I think the really disappointing thing for pioglitazone would be having a very different conversation if Proactive had have probably looked at different endpoints. Is the reality, but it didn't, and we're kind of stuck with the primary endpoint of trials. And the reality is that you design these big trials and you take a big gamble, but the whole thing is predicated on the basis of the primary endpoint, and then everything else is a little bit of buyer beware in terms of what you want to read into the data.
Jürgen?
I would definitely agree with the metformin cautionist. We know very little about metformin actually in cardiovascular disease. All the epidemiology looks very good for metformin, but then it's the first drug to the least sick patients, so we don't really know. It looks good, but we don't really know. We have no hard evidence except for this subgroup analysis of the UKPDS, which was a long time ago. So will certainly agree with you that we need now to make another group of studies which are actually there to prove benefit, not just no harm. And my question to you could be, for the UK PDS and the BADT study, it took a long time to show the benefit that seemed to be there. Actually, it was a long time post-trial. And to my knowledge, the FDA has not asked for any post-trial benefit survey of these studies. Is that really true?
Well, it's true, and I believe that they are in a bad position, the FDA, at this time. They are very much under pressure from the trialist and also European agency that they need really to change their guidance. They cannot go with the guidance of 2008, and certainly they would move on to cardiovascular efficacy trial. And this is really what we expect now. Well, maybe safety is enough in order to have approved for glucose lowering, but if drugs are to be approved for cardiovascular protection, we really need to mandate this long-term trial. But again, I agree that there is a real challenge related to the pathophysiology of the disease, and you may need really long-term exposures, and trials are just short-lived. I mean, you have seen Examine, 18-month median follow-up, so in order to have this long-term efficacy trial, you need a huge investment, and so far I can't see any industry going into this direction if they don't have a bonus. And the bonus may be just extension of patent life. And this is really on the agenda, and actually, by the way, not only in diabetes, in many other areas, because trials are becoming so expensive that, well, for good reason, industry are asking for some return on investment and some guarantee that they're not going to be challenged by generic in just short after they are on the market.
Oh, I've always found that patients are fascinating with the new guidance. I mean, you know, you've had nearly 100,000 patients enrolled in trials because of all of this, and you know, when we think about consenting patients for trials and we're asking them to do a lot, and you think about the psychology of why a patient goes in a trial, I mean, one of the reasons is because they think they might derive a benefit. And I've always been astounded over the course of the last 5 or 6 years with the number of patients who have been willing to go in trials where the outcome is really not to show a benefit. I mean, so we do need a rethink on all of this, but patients have been remarkable in terms of their ability to comply and contribute all of this data. It's been extraordinary.
Well, actually, I'm still very I can't understand how patients did consent to get into the trial because the consent form is written in a way where to explain that I'm enrolling you in the trial just to show that this drug doesn't harm you. Yeah. This is the primary objective, right? So some of the trials went to superiority as well, and I'm sure this facilitated the enrollment of patients. And especially the harm, the non-inferiority margin in these studies were 30%. This means we can accept 20-25% excess mortality, for example. So this model really need to be totally rethought.
But if we truly want to go down the line of really wanting to look for benefit, then we're going to have to start tailoring the patients that go into these studies. We need to stop assuming that every patient is at the risk of having an event, and that every patient's risk of having an event can be reduced by an intervention. We've learned a lot going back and looking at trials and registries. We know that not every diabetic is a coronary equivalent. We know not every diabetic with coronary disease is going to have an event. We've got a pretty reasonable idea for what drives those events. Why are we not using these factors in new trials to enrol the right patients in these trials? I don't know.
Absolutely. And related to that, I have two on-the-point questions. One for you, Dr. Znah, and that is, what is the role of the baseline level of cardiovascular risk on the outcome? Because some of that variability, the gray area when you say, strength of the evidence, to an extent, that's flying air. So what is the role, question is, of the baseline level of risk on the probability of success or failure of a trial?
Well, two elements for the answer. One very general, which is the higher the absolute risk, the higher the absolute risk reduction, So if you have a high event rate, you don't need to have tons of patients. So this is a very classical trick of trialists in order to enrich the trial by having many more events, because this is what drives the number needed to enroll is the number of events by the day, because all these trials are event-driven trials. So if you go for high risk, you have high event rate and you need fewer patients to enroll, so cheaper trial. So in a way, this is kind of artificial. But in this situation of safety trial, high cardiovascular risk is very important because, at least conceptually, you may believe that patients at very high risk, if they really stand and tolerate the drug, this is a good sign because, and especially in Examine, for example, 1 out of 4 patients had heart failure, yet we had no aggravation of heart failure.
Right,
So
but based on what you said a minute ago, doesn't this pose a little bit of an ethical issue? Because I'm going to enroll someone based on the fact that this patient is at very high risk, and the question is, can this drug kill you?
Well, I've said that I'm not totally supportive of this ADA model of cardiovascular safety trial, so it has to change sometime, and I'm sure it will change in the future, especially that now we have had enough of these trials.
Yeah, and related to that for you, Stephen, a question is there any way that the usual indicators of cardiovascular risk can be enriched by looking, for example, with imaging at the composition of the plaque, if that has any predictive value in terms of the outcome?
Well, we'd like to think so, but we don't have a strong body of evidence to support that. I'd love to be able to distinguish a patient who I think's got kind of a lipidic, inflamed, necrotic form of disease and triage them to more therapy because I think they're more likely to respond than somebody who's got a lot of plaque, but that plaque's all fibrosed and calcified. And the reality is they probably will. It ties into the last kind of question around this ACS cohort. Yes, we tend to pick these cohorts because they have a high event rate, but a lot of those events are driven by factors that are out of control of metabolic interventions. There's a lot of thrombotic events, there's a lot of arrhythmic events. There's no way in the world most of these interventions are going to have any impact on them at all. If you look at the lipid field, almost all of the lipid benefits, even in the statin trials, came after a year. We were lucky with 1 or 2 trials, and we think that then every lipid intervention is going to work early. And in fact, there's been a move away from ACS trials because those patients don't have the modifiable risk that comes along with the higher event rates.
But isn't it that the benefit with antihypertensive and lipid treatment is seen relatively quickly? This goes back to one comment that you were saying about the duration of the trial. I mean, generally, it's about 2 years before the curves start to diverge, whereas this is absolutely not the case with glycemic. You have to go to the legacy, to the post-trial. So does that imply that the damage due to hemoglobin A1C, because although this may only be a proxy, but we define diabetes by that. So it must be that, or something related to that. Now, we know that it takes a very long time to produce that damage, so is it reasonable to expect that the damage would be reversed with the same time course as you do with the antihypertensive or anti-lipid treatment?
I think years of exposure to hyperglycemia alters a lot in the wall of the vessel. It alters the epigenetics. It alters all of those elements that contribute to plaque vulnerability, and to think that it's just going to be the same rapidity of kind of response in terms of improvement, I think is wishful thinking.
The short answer would be at least the trials prove that you need a long time, because that is the only positive trials we've seen were in the post-trial period for a very long period after the trial stopped. So the evidence is that you're right, it takes a long time.
And I have another question for you, Jürgen, which is kind of related to what we're discussing. Is there any evidence that the degree of glycemic control post-ACS makes any difference at all?
There is no trial suggesting that in this group of patients, if you treat them for 5 years and have a tight control, they will do better than not. So the reasonable thing is to say that it is important that you control glycemia, and even to my opinion, it's more important that you have the right level for the right patient and the right drug for the right patient. Whether the level should be aiming at 7 point something or 6 point something in the individual patient, we don't know from any trial. So we can assume that having a stable, normal, or near normal glucose level is probably beneficial, but it is very important that we have no risk attributed by the treatment, and that's the best we can do.
So, would you, the cardiologist, say that what we've heard about ACS applies to stable cardiovascular disease? Or is this a different category in terms of risk factor, probability of failure, or success, or something like that?
Well, let me start. The time factor is really an issue. How long it would take in order to reverse or at least slow the progression. This is the single type of disease I know of where we would expect 5 or 10 years or more in order to have a therapy to be active. So it's a really challenge when it comes to performing trial. And post-acute coronary syndrome is a great way to enrich event rate in order to have smaller sample size. And by the way, we have only less than 5,000 patients in examined compared to 14,000 patients in other trials. I don't believe that glycemic control, and we have had it in the acute intervention in the acute coronary syndrome, would really suffice to control the excess risk. Glycemia in the acute setting is a great risk factor. But we have seen in the acute intervention trial, correcting glycemia, whether we did glucose, insulin, and whatever, is not really productive. So it's a totally different model. We don't know much. We know that in post-acute coronary syndrome, diabetes patients, even with normal ejection fraction, they have a very high rate of sudden death. And there is a trial ongoing now with 3,000 patients having a defibrillation versus no defibrillation in diabetes patients with normal ejection fraction in post-acute coronary syndrome. So this may be a short-lived complication which may be taken care of a very specific therapy within ICD. But when it's come to slow progression of micro and macro and also metabolic myopathy, the muscle in the heart is also diseased. So the pathophysiology is so complex, and this addition of the time factor makes it very challenging really to design trials in this area.
And absolutely related to that is the question, you said that the most prevalent cardiac problem in the diabetic is heart failure, maybe diastolic dysfunction, subclinical heart failure. So how do you cardiologists distinguish between post-ischemic heart failure versus the famous diabetic cardiomyopathy, which is an entity that has been in the textbooks for a long time without ever being clearly defined?
Well, we tend not to distinguish because they are all the same kind of disease when it comes to response to therapy.
But do you see patients with clean coronaries and heart failure?
Well, clean is just an overstatement, but certainly no thrombus and no single stenosis with just a lot of diffuse atherosclerosis. And we can see actually patients with microvascular with the reserve, coronary reserve, which is really very much diminished in diabetes. And in addition, the endothelial dysfunction. So the treatment of coronary artery disease in diabetes is totally different. And we have had this discussion early on with Jean-Claude about revascularization. The just simple angioplasty doesn't work much in diabetes. So it's just a different kind of cardiovascular disease.
When will we move away from one-size-fits-all treatment to individualized treatment? What a question to finish this.
Yeah, when we have better markers, I think we've got to move beyond reports in journal that factor X is associated with greater risk. to then truly using a marker or a panel of markers to triage to an approach and showing that that changes therapy and it changes outcomes. That's the next wave of implementation trials, I think, and when we do that, I think we'll be able to tailor therapy.
We are close to it in heart failure and the complications. Yeah. We now have great markers, not of prognostication of risk, but also of mechanistic pathways. So hopefully in the near future, we will have a bunch of multiplexes which could really segment this disease, and including diabetes cardiomyopathy in subsets. And indeed, one size cannot fit all because heart failure is so heterogeneous, and adding diabetes makes it even more heterogeneous. And having subsets of patients who would be candidate for specific therapy makes sense. So I believe in the future, this is the direction where really we are going.
Jürgen.
Yeah, just using the markers that we have actually, is the patient fat? Does he have a family history of cardiovascular disease, of type 2 diabetes? They might be very simple markers, but they might be very useful. And we are actually trying now in Denmark to sort of verify these in a prospective sense. Can we use them? Because the next biomarker it'll take a long time to get evidence, but the simple markers are there.
Final comment?
Look, I think our patients are desperate for this approach because they don't want to take 27 medications on a daily basis, and we can't afford it. So we're going to have to be smarter in terms of who gets triaged to which therapy.
Okay, if there are no further questions, because we've gone a bit over time, I should like, on your behalf, to thank the panel very much. I learned a lot from you today, and so I hope of you. And please, as you leave, don't forget to fill in the evaluation cards, which might be useful for next time. And thank you very much.